With enough repetitions of the same technical tasks, you develop intuition about it.
Well, thank you for being here. I would love to talk a lot about this, but if someone was to ask you, like, what do you do in a given week? You're involved in so many projects and things. I would love to just hear how do you respond to that if someone was to ask you, like, what does your week look like?
Well, the majority of my time, we have in medicine, we have a way of quantifying our time as effort. And so it's actually written down how much time I spend doing what I do. So the bulk of what I do is clinical medicine. So by 7:30 in the morning, I'm in an intensive care unit, rounding with the team in the ICU, looking at the kids that we've operated on and even kids we haven't. And in a multidisciplinary way, we quickly round in the ICU. And then the next chunk of my day from somewhere around 9 o'clock until early afternoon is in the operating room. And then when I'm done in the operating room, I usually have meetings stacked up, and those can be meetings related to my research, or they can be, we do all of our preoperative visits by telemedicine. Since COVID started, we started doing it, and it turns out that it's really efficient for families because they don't need to come to the hospital to see us. And we don't need to do a physical exam because many other physicians have seen the patient before we are going to operate on them. So oftentimes I don't even see the baby or child, but I speak with the parents about the upcoming operation. So I'll have telemedicine visits in the afternoon, and then usually I wind up my work sometime around 6, and I leave the hospital, leave work 7:30, something like that in the evening. So that's a typical day. And then if you stack up 5 of those together, that's a typical week. We don't operate every day, but nearly every day.
Yeah. And one thing I would love to kind of like ask upon that. So everyone that's here in our company, when I was telling them, meeting and getting the chance to interview a pediatric cardiac surgeon, a lot of them are always just like, I think for people that are outside looking at it, I'm sure in your world it's easy to, your network is cardiac surgeons, but a lot of them are just like amazed at the first question is like, how does someone get into that and that passion? It's clear, just reading your background, the projects you're involved with, even on the innovation side. How would you describe that?
Yeah, I think this is similar but different for me than for other pediatric heart surgeons. I have had a great drive to serve other people in my life in some meaningful way. And I had a sort of epiphanic experience at some point in my early 20s that I wanted to do medicine, and because that was what I associated with serving people. That's what I had seen in my childhood and growing up. So that's the driver, but I took a fairly long path to end up deciding to do this, and I didn't make one decision, like I want to be a pediatric heart surgeon, which some people come to, and bless them for doing that. But for me, it was incremental, and it just happened that the stuff that appealed to me the most, that has always appealed to me the most, has to do with specifically moms and babies. And I wanted to do something that had to do with moms and babies, and as a medical student, I saw OBGYN, which was the natural thing. Lots of women become OBGYNs. But it was, for me, somehow not a right fit. And then I thought about doing pediatrics. But again, the vast majority of babies are healthy, thank goodness. And so I wanted to do something different than that. And so I ended up doing research as a medical student. I was in a 5-year master's MD program.
Wow.
That was at UC Berkeley and UC San Francisco. And so during my time when I was at Berkeley, I did master's research, and I ended up working in Sub-Saharan Africa. And it wasn't like a coincidence, because I was really drawn to work again with moms and babies. So I ended up working in the 1990s during the big AIDS epidemic, the initial burst of AIDS in Sub-Saharan Africa, on maternal to fetal transmission of HIV, or maternal to newborn transmission of HIV through breast milk. So that was my master's thesis project. I went several times over the course of 3 years and stayed there for months at a time and doing research. And I ended up feeling like if I could do something technical that would help somebody, that was very tangible in a place where poverty is so endemic and entrenched and there's so much corruption, that working at the sort of, high infrastructural level, organizational level seemed very difficult to me to have an impact. And so I thought that what I could do would be like something that I could physically impact. And so I came back, decided that I wanted to be a surgeon, even though it really hadn't occurred to me until that point that I wanted to be a surgeon. And I took a lot of inspiration from my mom. And so I went to my mom and told her, like, I think I want to be a surgeon. And I struggled with this for a while because it really wasn't an archetype, you used the word archetype earlier, that I related to. And she was very gruff with me. She was just really impatient about it. And she was like, look, if you want to be a surgeon with a lot of expletives, like, you should just be an expletive surgeon. And so I was like, okay, well, I guess it's that easy. I guess I'll be a surgeon. And I felt like I wanted to stay in California. I had started my training there and I really loved living there. But I said to myself, like, the only reason I would leave California is if I matched in a Harvard training program. And so sure enough, that happened. And then it was my exposure to surgery in my training that led me to heart surgery. And I just knew because, again, it was like, at the time, in the place where I was training, I never told anybody that I wanted to be a heart surgeon until I applied in cardiac surgery. And people were pretty surprised, but it just wasn't something, believe it or not, at the time that I felt that I could share in the training environment where I was. And but I knew from doing abdominal surgery, which is most of what we do in general surgery training, that I would like always look up. There was a lot of laparoscopic surgery done at the time, so cameras inside the abdomen, and you can see the diaphragm, which is the muscle that separates the belly from the chest. And I would just always be looking up at the heart and its motion on the diaphragm. And then when I saw heart surgery for the first time as a resident, it's sort of an old school style of doing coronary surgery, which is adult acquired surgery. We would hold the heart. And so there's been some creativity in me over the course of my professional life. And when I was a medical student, my first summer, I wrote a poem that was about holding somebody's heart in my hands in this metaphoric but also literal way. We were operating on cadavers as medical students in our first summer. And so I wrote this poem, which is sort of the last poem that I wrote. I have an undergraduate degree in English. Seeing a body for the first time, a cadaver, as a medical student, which was, again, very impactful for me. And we operated on these cadavers to sort of learn our way around the human body. And so this poem was about holding somebody's heart. And then I, fast forward some years later, 5 years later, whatever it was, I was actually holding somebody's heart who was going to be alive. We stop the heart while we do heart surgery. So the heart was arrested, but I was holding it. And so that had an impression on me that, sort of goes beyond words, to hold someone else's heart. And the word intimacy doesn't quite describe it, because intimacy has all kinds of other implications in our culture, but it's sort of the most basic in some ways and most tangible way that you could experience somebody else's life force, their humanity. And to me, that was very resonant. And so I couldn't put it down. And again, in a sort of a metaphoric way, but also in a literal way. Like, that's what I've been pursuing for the last 2 decades.
Was that moment a heavy weight for you?
No, it was just work. And it was challenging because of the scenario, who I was working with at the time, right? Yeah. So the tradition of cardiac surgery at Mass General was a real force, and it wasn't there wasn't a whole lot of what you would think of as soft side of humanity within that force at the time at the MGH.
Yeah. Is that why the archetype thing, you didn't think you would go there? Is that why?
Well, I resist a unidimensional why, but I wasn't the prototype, right, that anyone would sort of pull out and say, like, she's our next generation. Yeah. And a lot has changed since then. But it was almost impossible for me to sort of envision myself. And so you said, what was the source of your decision. And I said, well, it was incremental, because at some point I couldn't envision myself doing this. And then I did it. So it was a lot of incremental decisions. I then decided to apply in cardiac surgery. There were 2 women in the US the year I applied in cardiac surgery. And then I did a cardiothoracic surgery training program. So it was, one decision after another. But my research experience during general surgery was in a pediatric heart surgery laboratory. And the people I worked with at Boston Children's at the time were, sort of leaders in the field from the first generation of the field. And so obviously very impactful for me, and really visionary people. And so extraordinary and very humbling to be in that environment where there are just so many really bright and visionary people. So that motivated me to become a congenital heart surgeon. And I went to one of these guys when I decided I wanted to do research, and said, I'd like to do research in your lab. And he said, well, what on earth would make you want to do this career? And I said, with all due respect, sir, I think I have the same character flaw as you do, and I need to do this. And he was like, he laughed, a person with a sense of humor, and said, all right, then, come on, you can work in my lab.
That's awesome. That's a phenomenal story. I'm curious, kind of still playing with this narrative for someone that's outside of your world. One thing I'd love to, I think people recognize the amount of things that you have to balance or that goes into the profession. What do you have to think through when you're in that operating room environment once you've kind of gotten into it? And could you kind of walk through, and maybe if it's a story, but like the pressures that go through your mind as being a pediatric cardiac surgeon?
Well, luckily, it doesn't happen all at once. So first there's training in surgery. And I think in many ways that the hardship that I faced in my training that almost doesn't exist in the same way anymore was very useful for me as a growth or learning tool. I know there are 168 hours in a week because we worked probably 140. There were no restrictions on work hours at the time when I trained. And so whether I was on call or not, it really didn't make a difference. I was in the hospital for most of the night, every night. And what we were responsible for was fairly vast. Some of those same traditions still exist, and in any training program, this is the lore of the training program or whatever. So we worked in the emergency department 24 hours on, 24 hours off. And for months at a time, we would work like that. So not a lot of sleep. And then we would be responsible for, even as an intern, so the first year, we would be responsible for every radiographic study, every x-ray, every head CT, every abdominal CT, every MRI of the extremity that was done in the emergency department, to report the results of those studies and show the pertinent findings every morning at 7 in the morning or something like that, 6:30 in the morning. There was an incredible amount of information that we needed to accumulate in a short period of time. So we had to be efficient. And this was, traumas and people who needed abdominal surgery and all kinds of things in the 24-hour period in the emergency department, a very high volume hospital. So that's the first part of the first lesson. And then I had some experience with physical endurance sports when I was a kid growing up. And so I think I applied those skills, whatever I had learned. And then there's just sort of survival. I had set my mind to doing this. And I didn't know what the outcome eventually would be, but I had said to myself, because it was so uncharacteristic at the time for somebody like me, a feminine woman, to choose a career in surgery, I said to myself, well, even if I don't ever practice as a surgeon, this is sort of how I gave myself an out, I want to have the experience of the training in surgery. So I did, and I was engaged myself in a way that I knew eventually, years into it, that I wasn't going to be a general surgeon. But I sort of played a game, a tool in my own mind that I wanted to pretend as if. So I applied myself as though that was what I was going to do with my life, even though I knew that it wasn't going to be, that I was going to move toward this other discipline of surgery that's actually technically very different. So I spent 9 years training in general surgery. So there's an accumulation of technical information, and then with enough repetitions of the same technical tasks, you develop intuition about it. So you start to build your unconscious competence. And I moonlighted also because I put myself through medical school and was supporting myself as a resident, and so had a lot of jobs as a medical student, and wanted to pay down some of my debt as a resident. I spent time moonlighting, and there was a very special adult heart surgeon who worked mostly by himself at a local hospital that was affiliated with the system that I was working in. And so I moonlighted for him. And he's a guy with just a very special spark. And so he taught me a lot. And I spent every weekend from Friday night until Monday morning moonlighting in that hospital. So the whole weekend I would spend working in the same hospital. So again, it's like you're so immersed in this experience.
How would you, I'm curious, like just to thread the training, like if you were to pick out like the hardest day, how would you describe like the feeling or the things that go through your mind? And it can be from like your training or currently now. What I really would love to kind of thread is you have a very kind of reflective mindset in the way you approach your training and your approach. So like these challenges, so like the way you work through them. I would love just like to hear, how do you describe like on your hardest day, like the feelings that you kind of have to think through or the challenges?
Some of the hardest parts are the physical rigor that's needed to stand for as long as we do, or to work for as long as we do. And again, that is built through training. And the fact that I trained at a time when there was a lot of physical gruel to the work that we did, I think it has served me. So that's one component that's hard. Another has to do with the preciousness of human life in the form of children. And someone was just saying to me earlier, like, I could never do that. And for me, those are real challenges, looking at parents of a child who is in a difficult circumstance, and knowing that that I may be able to help, and also there are limits to what we can accomplish. And so those are challenging situations, especially if there's some complication or something doesn't go as expected. To be able to navigate that with parents is exceedingly challenging. It's there's their psychology. They're the ones who live with this for their whole lives. And I've played a role for, an instant, a period of time. And so just sort of having that perspective, it's extremely humbling, even after so much training. And so I think those are some of the challenges that I encounter. But working with other people is very hard. And just like being with other people are hard. And so human interaction is fraught with, politics and agendas and things that aren't sort of the most essential part of the interaction. And so sort of navigating all of that for the good of the patient, the way that I've been able to do that, again, comes from my training, but to just focus on what's best for that patient as best as I can, and to let sort of some of the other stuff fall to the side and just be focused that way. So I think those are some of the elements. I have an emotional nature, and so to be able to process all of the emotion of myself and the people around me, I found very challenging. And I've developed some skills at doing that so that I can get through a day. And again, it harkens back to the sort of rigor of my training. We had to be awake for 3 days. We had these golden weekends where we would be on call. This was not moonlighting. I was on call as my job as a resident for 3 days in a row. And we would sleep a little bit here and there, but not a lot of sleep. And so we had to figure out how to interact with other people in a way that was productive, or mostly productive, even, amidst real sleep. And then the tensions of, human life and death. There are a lot of challenges there. And then it's it's just like anything else. I think it's just exposure and practice. So you develop a repertoire of ways of interacting. And I remember some big moments. I remember a patient's death when I was a resident, a young woman, and how I could see her family and her experience. It was a death from cancer, and so she had the opportunity to understand that she was dying. But these are things I was exposed to, and I didn't avoid. I experienced them and experienced the hardship associated with them as a physician, as somebody who wants to care for other people and see them flourish and thrive and be healthy. So I gained some comfort, sort of expanded my comfort zone to include a lot of possibilities. And so it makes it possible for me to engage with families knowing all of that. And so I'm comfortable. And they then are comfortable with the parameters of what is possible for their child's life. And then I stay with them as best I can. We're busy. And so I can't be there, every day to talk with them. But I show up again. And even if things aren't going well, I show up more so that they know that I haven't abandoned them or abandoned the contract that we have where I've told them I will take the best care of their child that I can.
That was, I think, like, to just kind of recap, because like outside from my view, kind of sitting here, it is truly amazing to think about wow factor of how many things you have to balance. Like the things that you mentioned was anywhere from the emotional side, connecting with parents, the actual child, communication with your team, the hard physical skill. So I'd love to kind of just lean into those a little bit more and understanding, like, kind of in all these years of training and where you are now, like maybe honing in on the skill of communication and the emotions that come onto you from the profession and wanting to really like lean in. What are some of the skills that have served you best in the profession when it comes to communicating or interacting with parents?
Yeah, these are the hardest things I find to talk about because we don't even have, I don't have a lot of language around these things, and they're mostly subconscious. So I'm not sure I can articulate, like, here are the 6 steps to, being able to talk with family, understand. And I think that's different from the approaches that I have seen and even what people have told me about what's possible, that informed consent is the process that we go through with families. And that isn't signing a piece of paper. It results in signing a piece of paper, but the conversation really has to do with informed and consent. And so the informed part means that it's part of my job to explain to the family what we'll do, what will happen to their child. And so I think one thing that brings parents great comfort is that I explain to them what it seems like, what it looks like, what it is like, and then what we have to do and what technology we use and where I see the risk. And it takes me a while to talk with families, usually an hour. I talk with them now by telemedicine, and I show them pictures and I draw for them. So recently I was operating on a child who came from outside the US. And so many people would make the assumption that a mom who is from outside of the US, from a non-English speaking country, that it would be impossible to have true informed consent. But I really think that people can understand that it's not really that hard. And so I have simple pictures and I draw on the pictures, or by Zoom I annotate the pictures and show parents how blood flows through the heart and what's abnormal about their child's heart. And these can be complicated things, but simplified so that they can understand. And I think understanding, like making something, here are the steps, this is what we need to do, and breaking it into its component parts for families is very reassuring that it's something they know what will happen. And then I sort of explain before and then during their baby's recovery, the child's recovery, and then what to expect when they go home. And I think that, sort of the story around their child's heart surgery, our brains are wired for these kinds of stories, and so that we find them comforting. And so just telling that story for them makes things clear. And then I try to preemptively answer their questions about how long it takes to do heart surgery. And then in our operating room, we have nurses who part of their job is to call the families and tell them, like, now we're on the heart and lung machine, now we're doing the inside the heart work, now we're off the heart and lung machine, everything's going fine.
So really a clear communication throughout the whole kind of process.
Right.
The one thing I'd love to kind of push into that outside the patient side, just to kind of like showcase, and like even for people that are entering your profession or that understand like what it takes to go in, you covered how you would talk with patient's family, and then you mentioned earlier the struggles that sometimes come up with team. I would love to kind of just end with some, what advice when you think about making sure that fluid motion goes well. So you mentioned like, how do you talk to the families? But when you think about your team in the setting and going into the OR, you were hitting on some notes of like making sure the nurses are really communicating. What advice would you give to like a young generation of surgeons coming into this field in order to make for a great team?
Yeah, that's a great question. I don't think we make a great team. I think the team makes themselves in a way that there's a culture in a team. People call it esprit de corps or something like that. And that culture is the thing that I told you I've been working with the same surgical partner for a long time, and we're interested in that by that culture. So we cultivate that. Our interaction, we try to let our interaction be a sort of a leader, an icon for how we want the culture to be. So the first part is to respect other people's training and skill. And there used to be this idea in surgery when I trained, in fact, that like there was a lone genius or the guy at the top or whatever, that sort of a thing. And we like the idea of a flatter hierarchy than that. And so we see ourselves as the team leaders, but not as like the guy at the top. And so we respect other people's skill sets. So that's first. We work with perfusionists, who are these physiologists who are master's level trained to run the heart and lung machine. So who's the expert at the heart and lung machine? Well, they are. They know the sort of technical parts of what we're doing, as do we. But we engage them and interact with them. And in an operating room, the form of communication is fairly routinized, the way it is like in all kinds of emergency situations, pilots, Navy SEALs, whomever. Like there's a formal communication that we use that's a shortcut in the operating room, and we know what it means. So we have that with the perfusionist, and there's a call and response system for safety reasons. So we say blue on, and they know what blue on means, and they say blue on, blue is on. So without a lot of words, we can sort of give each other feedback.
Close loop.
Close loop communication, and there's feedback about what's happening. So if something's going wrong in particular, we can troubleshoot together. And then there's a group of people, anesthesiologists, nurse anesthetists, who are at the front, at the head of the baby. And so we have communication with them, and usually that has more words to it, but in emergencies it doesn't. And then we have surgical scrubs, or people who are handing instruments. And again, like we try to use as few words as we can. And so right now I've moved to a new institution, and it takes a while. There's a big learning curve to what instrument we want in what situation. And so we've been working on that for the last 6 months or so, 9 months since my partner's been there. When we do this part, we need this set of stuff. And when we have this size child, we want this size of a particular instrument. So there's a relationship there as well. And then there are the circulating nurses who are in the environment. So there's a lot of people in the operating room, and people are stationed in particular geographic locations in the OR. And then there are certain forms of communication that are used with different groups of people. Most of the time in heart surgery operating rooms, there's no music and no other distraction. We listen to music in the operating room. We find that it brings this sort of comfort and a little bit of relaxation to the whole group in the OR as we're doing an operation. And then people understand when the most tense moments of a case are intuitively over time. And so that's when we sort of buckle down and just have essential communication. But we'll tell stories and make jokes and talk to each other when there are moments that aren't so intense. So it's like, a whole saga within the day of the operation that we go through. And in general, things go as expected and they go well. And then we, over time, as a team, develop systems for when they don't. So that's I think the sort of most fundamental.
Yeah, that was awesome at kind of painting the picture of what goes on. I had a chance to shadow robotic heart surgeon in May, and just the dynamics you explained, it was a very kind of flat surface or flat kind of organizational structure in the room. Who were very calm in the moments that weren't intense, like those jokes. I'd love to end just a really like quick question. But if you were to like have a lesson that you wish you learned earlier in your career and explain it to someone like, a few sentences, like what's the lesson you wish you had learned earlier in your training?
Well, the one that occurs to me today, and I'm sure that there are more, but the first one that occurs to me is that life is finite, and so to be worried about what other people think isn't very helpful. And so I think that concern or consideration is a part of people's calculus that holds us back. And so if I had been less concerned by that earlier in my career, I think it may have accelerated my progress in many ways. Our specialty is extremely scrutinized in terms of our outcomes, and so we're sort of forced to continually think about what other people think because we're measured. But in some ways, you have to abandon that to really be able to excel, not be limited by that. So that would be one piece of advice that I would give myself. Easy to say, hard to follow.
Hard to do, yeah. Well, thank you so much for your time today, and really enjoyed this conversation and just learning about your world and also your journey.
Thank you.